starting recording and transcription, and let me just stop the transcription. Okay, so today we've got our very own Hem, who's going to talk to us about the neuromodulation service and provide a few updates on how things have changed over the years. So it'll be really interesting because we see a lot of patients coming through, and it'd be nice to know who we can consider referring down that pathway and what that pathway looks like. So I'm going to hand over to Hem to share his screen and do the presentation, and as usual, we'll be asked questions at the end.
Thanks, Selena. Hi, everyone. So everyone knows me, I hope. I met every one of you in person. So today's update, I don't know if we can call an update. It's basics about neuromodulation, on what neuromodulation is, some mechanisms behind it, what we offer at Walton, what's offered in the pain service, what's offered in the neurosurgery service, the functional neurosurgery service. So we are going just a tiny bit about that, and any questions at all, if you want to expand on any particular topic of what we're going to discuss, more than happy, and stop me if you want to discuss further. So let me share my screen. I hope that's visible.
Yeah, it is for me. Yeah.
Okay. So what is neuromodulation? Yeah, neuromodulation can be it can be chemical, it can be electrical, it can be physical. So any alteration of a nerve activity, or if we are enhancing, or if we are dampening a nerve activity through delivery of a stimulus, is called neuromodulation. All our medications that we use are neuromodulators. They activate certain nerves, they can dampen certain nerves, but majorly we are going to discuss about electrical stimulation for the update today. So what all, a few which have been offered at for neuromodulation side in Walton Center would include spinal cord stimulator, DRG stimulators, peripheral nerve stimulator, sacral nerve stimulator, and we are soon going to start multifidus, lumbar multifidus stimulation as well for chronic low back pain, which is non-specific. So these are the few neuromodulation that's been done all over the body. So it includes deep brain stimulation, which is offered from the functional neurosurgery side here at Walton, including movement disorders, in epilepsy as well. That deep brain stimulation initially used to be offered for pain, but currently it's not offered. There are other modalities which are much more capable in controlling pain. There are also vagal nerve stimulators for epilepsy as well as depression. But majorly, we are going to speak about spinal cord stimulation, sacral nerve stimulation, and peripheral nerve stimulation as well. So where can we stimulate? This is pathway of a nerve from the spinal cord. Excluding deep brain stimulation, for pain, we can stimulate the nerve right at the level of the spinal cord or dorsal column, where a traditional spinal cord stimulator lead would sit, or we can stimulate the nerve at the level of DRG, or at the level of the dorsal root ganglion. Further going down, we can stimulate the peripheral nerve itself by peripheral nerve stimulation, by electrodes placing percutaneously adjacent to a peripheral nerve, or we can also stimulate at the very end branches. That will be field stimulation, where millions of tiny nerves they divide and supply the field, a particular field over skin. So what is spinal cord stimulation? Again, by definition, we are trying to alter the activity of a nerve. We are trying to modulate the activity of a nerve, and we're trying to alter the perception of neuropathic pain or ischemic pain by stimulating the dorsal column of the spinal cord. Like we said, we're trying to stimulate the dorsal column of the spinal cord over there. So for any neuromodulation, you'll need a battery which will produce the electrical signals, appropriate signals, appropriate pathways, appropriate programs to generate very specific waves of electrical signals. And this signal need to be delivered to the site. So in spinal cord stimulation, that site would be in and around the spinal cord. So that we need an electrode to deliver this signal. So that can be a cylindrical electrode, which is placed percutaneously, or it can be a paddle electrode, which is placed by laminotomy, which is opening the lamina of the spine. And to control these two devices, we'll need a remote control, which can increase the intensity, decrease the intensity, change the pattern of wave according to whatever we desire. So we need these three components, and once these three components are there, we can place these components anywhere, maybe in the cervical spine, in the thoracolumbar spine, depending on the area where we need to capture the pain signal. We can try to modulate the pain signals by placing the electrode where we need coverage. So how does a spinal cord stimulator work? There is no clear-cut mechanisms yet, as it has been for many years. There has been a few proposed mechanisms for spinal cord stimulator. First, like the run-of-the-mill would be the gate theory. So everything is with gate theory with wide dynamic range neurons. So I suppose everyone here has understanding of what the gate theory is. It's the A beta fiber stimulating the inhibitory neuron, which in turn stops the C fiber from projecting into the spinal cord. And this is being potentiated by spinal cord stimulator. Next comes inhibitory signals in the spinal cord. So the GABA receptor is one of the inhibitory neuron, which can stop pain signals from being transmitted through the spinal cord. These SES potentiates this neuron as well. And we all know about the descending inhibition that the brain sends downwards to counteract the ascending pathways which produce pain. So this is the inhibitory pathway that's coming downwards from the brain, including serotonin and non-adrenergic pathway. So some spinal cord stimulator can activate this pathway and potentiate this pathway as well. Immunity as part of propagation in chronic pain is being studied very widely now, and neuroimmune cells, especially the glial cells and astrocytes, are a major part in propagating chronic pain, in maintaining chronic pain. They continuously produce those inflammatory chemicals which keeps chronic pain alive. Spinal cord stimulator plays some part in decreasing the neuroimmune response and tries to stop the propagation of chronic pain and maintaining chronic pain alive as well. Also, as spinal cord plays some part in helping with ischemic pain as well as anginal pain, it also helps in suppression of sympathetic fibers, which also plays some part in a controversial part in CRPS. Also, it produces vasodilatory proteins, which improves ischemia as well as which improves anginal pain as well. So that's spinal cord stimulator. Moving on to sacral nerve stimulation. Most of our patients for sacral nerve stimulation are still patients with bladder sensitivity, who will be having overactive bladder, which is our most common patient cohort. We do get patients with urge incontinence, meaning that they don't feel the fullness, but when the fullness is there, they have to go to the toilet very urgently, and they have accidents with it, and they have urgency and increased frequency as well. So these are the patients who we usually see for sacral neuromodulation. Other indications include fecal incontinence, and also with our female pelvic pain clinic as well as from male pelvic pain clinic, we do get patients not infrequently who have neuropathic pain in the pelvis. This can be chronic neuropathic pain, like having any nerve injury, having parental neuralgia, but mostly pelvic pain associated with bladder symptoms are our usual cohort. They can be chronic bladder pain syndrome or other bladder issues associated with chronic pain. Usually, the outcomes for patients not having pain, if it's only bladder activity that's being hampered, their outcomes are slightly better. Usually, in pelvic pain, pelvic pain becomes a confounding factor, limiting positive outcome from a sacral nerve stimulation. So again, we try to place the lead in S3 foramen. So this includes a trial phase where we do stimulation on both sides, and depending on the benefit that patient gets from, if one side is better than the other, permanent implant is advised on the side where they have better outcomes. We put the lead into the S3 foramen as it slightly comes out through the anterior foramen, and the IPG is placed in the buttock area. So that's the lead for sacral nerve stimulation. So the lead is different because it has plastic tines which anchors itself between the muscles in the pelvis, and this doesn't come with a separate anchor. Okay, so multifidus stimulation is pretty new. It's pretty new to the UK. It's pretty new to Walton Center. It has been NICE approved last year, end of last year. So what it specifically entails for is to stimulate multifidus muscle, especially the multifidus muscle supplied by L2 medial branch or L2 medial branch, which is on top of L3 transverse process. We try to stimulate that specific nerve, and because that muscle is probably the largest of the multifidus muscle, and based on the stimulation, we try to achieve the neuromuscular control back around the lumbar multifidus muscle, which in turn, in long term, helps to stabilize the spinal column and reduce chronic pain. Multifidus inactivity has been like most of the patients with chronic low back pain, which is non-specific, which is not neuropathic in nature. Mainly, this pain needs to be nociceptive rather than neuropathic. This chronic pain will help. Sorry, this device will help these patients. So when there is instability or when there is multifidus weakness, there is proprioceptive feedback to the brain. So when we stimulate this specific nerve, this feedback is potentiated, and there is neural drive from the brain to improve the stability around the multifidus muscle, which is being stimulated, which in turn increases stability and movement long term. So this stimulation doesn't provide results immediately like spinal cord stimulator or sacral nerve stimulation. Most often than not, it takes months, if not maybe some patients have even showed a year for regaining some amount of pain relief. And this is a typical patients who we see quite often with severe atrophy of multifidus muscle. The researchers say that these multifidus muscle atrophy needs to be at the level of L3 or L4 rather than going at L5 level, because they say most of the patients at L5 level invariably have atrophy. So the multifidus muscle which we are stimulating, the bulk is at L3 or L4 level. So if there is atrophy at this level, these patients are gain more benefit from this treatment. There are a few physical examination that needs to be done before offering the multifidus stimulation. I'm going to present in detail about the reactivate therapy and multifidus stimulation in the pain service meeting, I think probably in a couple of weeks' time. So that will be a much detailed presentation with regards to this. Okay, again, going back to indications, the NICE guidelines for SES is for failed back surgery syndrome who have chronic neuropathic back pain and chronic neuropathic leg pain, and SENSA has been approved for chronic neuropathic back pain as well. But in general, NICE also approves for neuropathic pain, which is not amenable to usual treatment, and the pain has been present for more than 6 months. For CRPS, which can have non-neuropathic causes as well as for ischemia and angina, where there's no clear-cut guidelines on this, but it can be offered for ischemia and angina as well. Peripheral nerve stimulation or field stimulation is currently being offered by functional neurosurgery by Ms. Bagua and team. It entails placing a nerve, placing a electrode around the peripheral nerve. The criteria would be the chronic neuropathic pain, which is not amenable to SES, meaning some areas in the body, some region in the body might be quite difficult to obtain with spinal cord stimulation. Like sometimes foot might be difficult, sometimes groin might be difficult, or any particular area in the body might be difficult to obtain. So peripheral nerve stimulation might be an option for them. Or if there is a localized field, neuropathic pain in a localized field, like for example, if patients are having occipital neuralgia, occipital nerve field stimulation is an option for them. We discussed about sacral nerve stimulation, where bladder overactivity, urgent incontinence frequency has been discussed about, and also fecal incontinence as well, who might get benefit from peripheral stimulation of tibial nerve stimulation, but if those things fail, they can go ahead for sacral nerve stimulation. Multiplicative stimulation, we have discussed it just now. So our current pathway has been, I don't think it has been changed in the recent times. So there is initial medical assessment by the medic, then the patient's referred to MDT assessment. They go through psychology assessment, and we get some recommendations from the psychologist, or if there is no confounding factors, then they're straight ahead, they go into specialist nurse assessment, and after the nurse assessment or nurse education session as well, they go ahead for a review by the medic again and go ahead with trial. Some patients who might be quite complex, or if some patients do need optimization before going in for the treatment itself, they are discussed in the multidisciplinary team case conference, where the issues are discussed and how to optimize them before going ahead for the trial, or if the team feels that the patient might not be appropriate for this pathway, for this treatment is discussed as well. So that's the update, and thank you so much. I'm open for questions.
Thank you, Hem. That's really interesting. Has anybody got any questions?
So I'm on time. Yeah, Alison said 30 minutes, so I'm right on 30 minutes now.
Wow. Nat, you've got your hand raised.
Oh yeah, it was delayed and then it's pinged off again. Sorry. It's always tricky to know how long to wait for the hands to pop up, isn't it? With everyone's slow computers. Yeah, you know, don't make me say the name of the muscle, because I was only just learning from Helen about this, but I know it from Reactivate, the Reactivate trial. Is that right? That muscle, so that the new developments that we're going to within the service. Just a really open one for that. What are you? Because it's not even been talked about in many of the team meetings, has it? So how, as a service, even if it's fine just from a medical point of view, what's the development trajectory for Reactivate trial? For those of you that are like, that was the name of the research project, wasn't it, for this particular type of stimulation? And Helen was saying it's about just activating a particular muscle to decrease lower back pain, and the trial's all being completed and outcomes are published, and the centre is now committed to clinically offering this. So can you fill us in a little bit more on what's happening with that then, Hem, please?
Thanks, Rocklin. So at present, we have not done any patients outside the trial. So we had a post-market trial which was offered at Walton Center. I think we had about around 10 patients who went through implant, but that was all sponsored by the company. And now they are all, so it's for 5 years. So that 5 years is completed now. So they are all moving to the service now. But since the NICE publication of approving multifitter stimulation to be used, this has been put forward through clinical governance as well. And from the training as from the medic aspect, me, Dr. Sharma, Mr. Farah, and Ms. Bhagwa has been trained, and we four are going to offer the treatment. NICE still recommends it needs to go through multidisciplinary team assessment. So it will be like any other spinal cord, any other neuromodulation pathway. So like spinal cord stimulation, the patient would be assessed by medic. If they are appropriate for the treatment, they will go through the multidisciplinary team assessment, and they will be seen by the medic again before going ahead for the procedure. The alteration in this treatment is this treatment doesn't come with a trial like spinal cord stimulator. You have to straight away go for the implant of the device. So most patients who we see, they have mixed nature of pain. So they have some neuropathic features. They have some low back pain, like nociceptive mechanical low back pain features. So still, if for me, if they have mixed features, I will still put them forward for spinal cord stimulator, because we can trial a spinal cord stimulator. We can't trial this device. So that's my idea behind it. But again, we have not started offering this to patients yet. So like Dr. Lane said, we have to have a proper plan on how the patient pathway is going to be, who to choose, who not to choose, mainly because I know we have thousands of these patients waiting already. So we have to make those clear-cut definitions before we start offering this to the masses. So for the pain service meeting in a couple of weeks' time, I'm just going to broadly pitch about what this procedure is, who will be an appropriate patient, who won't be an appropriate patient, how it is different from spinal cord stimulator, and what should we let the patients know about the procedure. So all this, I'll try to put a lengthier presentation on specifically multifitter stimulation in a couple of weeks' time. So that's where we are now.
Okay. Has there been talk about linking this to trying to get another physio and trying to put towards a business case for a physio for NMOD, or is that a bit pie in the sky, do you think?
I think there has been push. There has been push from Dr. Sharma as well. But I don't think the intention is reciprocated from the other side. So the two options we have is to wait for a physio in the NMOD team, or the next option is to start offering the service. We are just weighing these two options now. Can we wait till we get a physio to offer the service, or should we go ahead and offer the service now? And probably keep an eye out to include someone in the service as we go by.
Okay, thank you.
Because I think, Dr. Lim, most of the patients, if you see if this kind of pain would have been assessed by a physio, they would have had a lot of physio input already. But saying that a specific neuromodulation physio in the team who will like it should be part of the screening as well. So it makes sense to have a physio.
Definitely.
But yeah, there are
But
some.
that even what you've said there, that's really important if you're looking at inclusion and exclusion, because Helen said, not to speak on behalf of all the physios, so please take over if what I'm saying is inappropriate, Selena, but they she was saying from a physio point of view, how on earth are you going to select the right candidate from the hundreds, if not thousands, that could potentially be being referred to the centre? But if you were saying even a first one is those that have already tried, and absolutely the right. So are we potentially saying those that have had what we know to be good quality pain physiotherapy input already? So they have to have had that at a first level.
Yeah, I think this Manish and Nicola has a lot of these patients. They do the spinal pain clinic.
Spinal, yeah.
So they have like thousands of patients, and like Manish asked me, because most often they're not. They report to this patient saying that there is no specific medical treatment available for this non-specific back pain. So they are invariably pushed into, they're invariably given an option of a self-management, PNP, physio input going forwards. But if this treatment is available in NHS, and if you are not offering it, then it might not be appropriate. So that's the reason we are planning to start this service as soon as possible. Really,
yeah. Okay, great, thank you. Sorry, John, I did about 3 questions there.
Yeah, so I was probably twofold really. The first one was kind of linked to what people are saying, is that what strikes me in this sort of lineup here is the therapy is missing from the sort of MDT side of things at the moment. You know, I know there's been a few reasons why that might be, but also I was thinking about, you know, what outcomes you use to measure, you know, how effective spinal cord stimulation is.
So obviously pain relief is so the outcomes, by outcomes you mean post trial outcomes or post implant outcomes?
I guess, like, for, you know, what do you measure? How do you measure the effectiveness of it? You know, is it like what you do at assessment and what you do afterwards to test if it's actually had the impact you wanted it to?
So we do an assessment post trial to see if they're appropriate for an implant, right? So this trial it's for 7 days, or probably maximum would be for 10 days. We get only little bit of information of whatever we have in these 7 days. One would be obviously pain at rest, pain at movement, pain walking, their ability to sit and stand and walk, and how does it differ pre and post trial. In general, how the patient felt, their subjective improvement in pain scores, or subjective improvement in their overall quality of life is also asked for. So most centers use a number. If they say at least 50% or more, the pain relief at least 50% or more. Some of them even aim for high 80% or like even more than that. But at present we are using subjective improvement, even if the numbers doesn't show more than 50%. So for some patients, we discussed this with the patient, saying that long-term outcomes might not be what's expected. If they're having 30-40% pain relief, in long term, that pain relief might go down. So we discussed this with the patient before going it for an implant. But if they still feel, or if the patient is still feels that subjectively it's going to help them, then sometimes we do go ahead with an implant. Post implant, there are scores sent out to the patient. I think in a few weeks' time, and as well as in 6 months' time, on improvement in pain scores again, improvement in quality of life by I'm really it's not crossing my mind what scores we use. I think we use EQ5D for quality of life, and general.
Do they use the ODI pen?
We use ODI as well. ODI is used before and after as well. and general pain scores, numerical rating score, rating scale would be part of it as well. Yeah. And yeah, this part of the neuromodulation registry as well. So there are specifics that needs to be filled in the neuromodulation registry. So that's collected by the outcomes team anyway.
The mood measure ones are the HADs. So
Yeah.
we've followed the UK registry one, which has limited us for assessment from a site point of view. We add in the pain catastrophizing and I think the self-efficacy just to double check things. But to be honest, since COVID, we've been a bit slapdash on looking at the scores, to be honest, since the pandemic, because we're not able to collect them. And we've never overly clinically used them. It's more just been research, really. But if your thoughts, John, are going to, there's a difference between us assessing functional change and then supporting that with input and furthering it and optimizing it than just capturing it in the ODI. That's obviously where physio and pain psychology's hopes are for further development within the service. Yeah. Anyway.
Yeah, because that's what I was going to say is that, you know, from what you said, it sounds like the big missing gap is functional improvement, and how you sort of measure that, or even, you know, supplement and complement that with what's being done. So obviously, as an OT, that's where mine goes. But
moving forwards, John, I think most of the centers all across the world, they're moving towards more objective scores. Like most of the centers are using Fitbit, like some form of device that patient needs to wear for throughout the trial phase. So even though we rely on patients' own words, we do have some form of like an objective saying that, you know, their sleep has improved, their walking has improved, their steps has improved. So even though pain is subjective, we can have a functional measure there as well. So moving forward, this is a really good thing we can think about. Maybe even we can do like a research as well on this, if that can be implemented in our routine service. Yeah.
Great, thank you. Graham, you've got your hand raised.
Hi, Graham.
Graham, you sound quite awful.
Can't hear you, Graham.
Graham, do you want to type in the chat?
Or he could pop next door. Has Graham gone somewhere since this morning? Because he's only up the up the corridor. He could run into Louise or my or Nathan's room.
It sounds like it's at the bottom of a swimming pool, doesn't it?
It did. I was like, is he in his car on the way home or something?
Completely gone.
I can hear movement. Yeah, here he is. He's gone into Lou's room.
There he is. Sorry about that. Computer's playing up a little bit there. Yeah, it was just, and I think you might be going through some of this at the pain services meeting about the reactivate device head.
Yeah.
So I won't yet. If you're going to cover it, then that's fine. It was just a quick question about how you identified this like reduced activity in the multiplicative puzzle.
The reduced.
Do you know when you said identifying the patients, obviously the reactivate device, from my understanding?
Okay, so first thing is
the rationale is that it's sort of suggesting that there's reduced activity in the multifidus muscle, and that's what's contributing to like instability of the spine, and that contributes to pain. How do you identify those patients with the reduced activity in the muscle?
So there are a few tests which has been proposed. I can show you the tests now. Just give me 2 seconds. And also on top of this, there is also MRI scans which shows atrophy of the multifidus, like the image that I showed. Sorry, 1 second. I'm just bringing on the presentation. Okay, can I share my screen? Yes, that's okay. Okay. So, yeah, difference would be clinically. Patient feels that movement aggravates the pain, mechanical pain. If they maintain a position, the pain can get worse. If they bend forwards, the pain can get worse. They always feel their back is unstable. They get sudden pain and sudden spasms in the back. Even bending forwards, like brushing a teeth, bending over a sink, anything bending forwards can worsen their pain. And these are the tests, if you can see. I usually do the prone instability test, make them lie on the examination table, and asking them where the pain is. I give some pressure on that painful area and ask them to lift their leg, which engages the multifidus muscle, and their pain gets better. The test in the middle. So all this, I'm going to present all this in the pain service meeting in a couple of weeks, Graham. And also, yeah, we discussed about the severity and atrophy of the multifidus. And we differentiate between neuropathic back pain and nociceptive back pain, like the mechanical back pain that we get. The difference of having neuropathic symptoms, burning sensation, sharp sensation, all this would go into neuropathic features, or looking into more of nociceptive or chronic low back pain kind of symptoms would go would be more appropriate for reactivate therapy. Yeah, so that's. Does that answer your question, Graham?
Yeah, it's just, yeah, thank you for that, Hem.
I can send you the presentation if you want, Graham. I can send you, email you those slides. If you want.
That'll be interesting to see, definitely, because I know in our clinics we see a range of patients who we sometimes see the opposite of, where they're quite hypertonic around those muscles. So often they're like very guarded and protective, and then often learning to like let go of those muscles is the things what can give them like freeness in the movement. So I suppose the trick here is making sure it's the selection of the correct patients, because and also that word, I suppose, unstable. I think our modern day understanding around the spine is it's not an unstable structure. It's actually a really strong structure. So it's not hoping not to put more fear into patients, if that makes sense, Ham.
Yeah, I think it's more of what the patient perceives. It's not that saying the word unstable to the patient. Sometimes, so what I do is I don't say that your spine is unstable. I ask them, do you feel your spine being unstable? It's more of the patient's subjective feeling that they have, but I don't reinforce that. I don't reinforce saying that, your spine is unstable. I probably most often I say that the muscles supporting your spine might not be as strong as it needs to be. Those are the words that I say instead of saying it unstable, because those slides are from the company, so they use inappropriate words. So I completely understand that. So
I did manage to have a look at the company what does it, and there's some scary messages on that website, Hem. It's quite worrying for our patients if that's where they go to get their information, and especially when our patients are already quite anxious about the nature, the cause of their spinal pain. Often it is things like, I think it's unstable, or I think it's all these scary things. But yeah, thank you for that, Ham. I'm going to come in for your talk in the pain service.
Yeah.
So nice to hear what you've got to say.
Yeah, absolutely, yeah.
Thanks very much.
Thanks, Ram.
Has anybody else got any questions for him? I feel like you've had quite a few. I think there's been some really good points raised there, and some nice, there's obviously new developments, but a lot of considerations that need to support those new developments. and particularly sort of business cases if you're going to get further therapies involved as well. So always tricky questions for you to be put on the spot to answer, Hem, as well. So thank you very much, and thanks for sharing. I'll stop the recording now. Stop. There we go.